Okay, so with this we can start today's session. I'm little sorry for being so late, but anyway, I was just preparing the session, and once it is prepared, then I thought that it's better I should come live now, right? So today I have selected few questions from physiology, and most of the questions are from very important topics, and yes, I have just tried to frame them in a lengthy style, and some conceptual or related to integrated with medicine, of course. So I am very sure you must enjoy the session. Okay, so starting with the very first question, it was about a 45-year-old man with severe hemorrhagic loss, which was about 25% of his blood volume. And then the question was like, which compensatory mechanism is activated first to maintain arterial blood pressure? So the question is very basic, like there is hemorrhage, right? So obviously this will result in fall in arterial blood pressure. Now, which mechanism will be activated first to restore or to maintain the arterial blood pressure? Now, this concept is about baroreceptor reflex. Okay, so this concept is about baroreceptor reflex. I think all of you must be knowing what do you mean by the word baro. Baro is pressure, right? So what happens whenever there is a fall in the arterial blood pressure, there is less stretching of baroreceptors. Okay, so there is less stretching of baroreceptors, and this what initiates the baroreceptor reflex. So this is a mechanism, this is the mechanism by which the baroreceptor will restore the arterial blood pressure. Now how it will restore, and okay, before that, what are the location of baroreceptors? One is carotid sinus, and another is in aortic arch. Okay, so please remember these locations: carotid sinus, aortic arch. So once there is less stretching of these baroreceptors, there is generation or activation of the baroreceptor reflex, and yes, this is the first mechanism, right? So this is the first mechanism, and what it will do, it will decrease parasympathetic, clear? So it will decrease parasympathetic, and obviously it will increase sympathetic. Okay, so it will decrease parasympathetic, or what you call, it will decrease vagal tone, and it will increase sympathetic. Now I think most of you must be knowing that whenever there is decrease in parasympathetic, this will increase the heart rate. Okay, this will increase the heart rate. Now whenever there is increase in parasympathetic, what it will do, it will increase inotropy, that is force of contraction of the heart, right? So inotropy is force of contraction of heart, right? That is one thing. And it will also increase the arteriolar resistance, and this is total peripheral resistance. So it will cause constriction of the arterioles. So this is how it will increase the arterial pressure. So this is how the arterial pressure is maintained at the earliest by the involvement of baroreceptor reflex, right? So answer for this question will come out to be your baroreceptor mediated sympathetic activation, right? So this is the first response to fall in arterial blood pressure, which will happen because of hemorrhage, right? And yes, there is later on there might be activation of the renin, angiotensin, aldosterone system as well, but the first is baroreceptor reflex. Okay, so please remember this. So this is the importance of baroreceptor reflex. So this image I have kept for your review later on from the annotated PDFs. Now moving forward to second question. Now most of the questions are like, if you read the question, you can think, okay, this could be the probable answer. So I have kept questions like that only. So most of the questions you can try to answer, right? So like there is a young athlete who has a resting heart rate of 46 per minute, right? 46 beats per minute. But he is asymptomatic. Echocardiography is also normal. Now, which physiological adaptation best explains this finding? Now here, the given case is a athlete and his heart rate, resting heart rate is 46 beats per minute. And no problem, so he is asymptomatic and echo is also normal. So it means there is no disease at all. So there is no heart disease, right? Now this heart rate is very less and this is known as sinus bradycardia, right? So what is this known as? Sinus bradycardia. It means everything is normal, it is not because of any disease. Now what can be the reason here? In the previous question I told you that if there is any inhibition of parasympathetic activity, the heart rate will increase. So that means if the parasympathetic activity is more, there will be fall in heart rate. So this what happens in athletes who are trained for a long period of time. What happens? There is increased vagal tone, right? Vagal tone is parasympathetic. Please remember that. And obviously the opposite is less sympathetic. Clear? So what is actually happening? Parasympathetic is more, sympathetic is less, and therefore the heart rate is less. And this is not related to any disease. Therefore, patient is not having any problem. Any evaluation of the heart function is absolutely normal. So this is sinus bradycardia, which is commonly seen in athletes because the parasympathetic activity is more. So this is the physiological explanation to this endurance training for athletes. Now here one must say that if the heart rate is less, then how the cardiac output is maintained? So how the cardiac output is maintained? Now this is maintained because there is increased stroke volume. Okay, so this is because the stroke volume is increased. So despite a low heart rate, cardiac output is maintained because the stroke volume is increased. And I think most of you must be knowing what is stroke volume. It is the amount of blood pumped out from the ventricles with each heartbeat. Okay, so that's stroke volume. I think most of you must be knowing. So this is the basic explanation for sinus bradycardia in an athlete. Increased parasympathetic or vagal tone to the SA note. Now moving forward to one more very important topic, aortic regurgitation. Right? So very important from medicine point of view, aortic regurgitation. Now here how the question is integrated with physiology and medicine. Let's see. A patient with severe aortic regurgitation has a blood pressure of 160 upon 50 millimeter of mercury. Now, which physiological mechanism is primarily responsible for the markedly widened pulse pressure? Now, I think most of you must be knowing what we mean by the word pulse pressure. Pulse pressure is the difference of systolic with diastolic, right? So in the given case, the blood pressure is 160 upon 50. So what we will do, we will do it like this, and this will come out to be 110 millimeter of mercury, right? So this is the pulse pressure in the given case. Now the question is, why the pulse pressure is so high? Because if we take the case of a normal person, what we usually teach, 120 upon 80 millimeter of mercury. So pulse pressure will come out to be 40. Okay, so this is somewhat normal, but here you see it is 110. Now why this pulse pressure is so high? Bhuvana Raghu. Okay, let me explain a little bit more, and then I think you will never forget this particular concept. Now what happens, suppose if this is the left ventricle, okay, on the top of that is left atrium, then here we have the mitral valve, okay, and here say this is aorta, and here is the aortic valve. Now normal physiology, so this is left atrium, left ventricle, and say aorta. Now the normal physiology is that the blood from the left ventricle should go into aorta, and then the aortic valve should close so that there is no backflow of the blood from aorta to left ventricle. That is normal. But what is happening in cases of aortic regurgitation, the incompetent aortic valve is not able to restrict the backflow. So what will happen? The moment the ventricle is contracting, the blood will go into aorta, but as soon as the systole part is over, the blood will go back into left ventricle. So what will happen? Because of this backflow of blood from aorta to left ventricle in diastole, so what will happen? The diastolic blood pressure will fall. Clear? Because if the blood has remained in the aorta, then only it could have contributed to the diastolic pressure. But now what is doing? It's going back into the left ventricle, so diastolic blood pressure will fall. Now during diastole, the left ventricle is receiving blood from left atrium also, like this. And then what is happening? This is the normal flow of blood from left atrium to left ventricle, but this is abnormal flow of blood from aorta to left ventricle. So left ventricle is receiving excess of blood, right? So left ventricle is receiving excess of blood. And why this excess of blood? Because one amount of blood is coming from left atrium and another is coming from aorta. So this all is pooling into the left ventricle, and therefore when the left ventricle will contract, the stroke volume will be more. So more stroke volume because it is receiving more blood. So this will increase the systolic blood pressure. So what is happening? The systolic blood pressure is increasing and the diastolic blood pressure is decreasing. Clear? And that's why we see the systolic is around 160, diastolic is only around 50, and therefore the difference between the two is too high. So that is aortic regurgitation. So what is happening? There is increased stroke volume. And why stroke volume is more? Because the normal amount of blood which is coming from the left atrium, it is mixed with the backflow of the blood from the aorta into the left ventricle. So left ventricle as such is receiving a lot amount of blood, and therefore it has to push lot amount of blood into aorta. So stroke volume will increase if we know the principle of Starling's law. And then so this will increase the systolic blood pressure. So this will increase the systolic blood pressure. And then in diastole, the blood is moving back into the left ventricle from the aorta. So as a result of this, the diastolic blood pressure is decreasing. Clear? So this is the concept why we see a widened pulse pressure in aortic regurgitation, because the blood is moving back from the aorta into the left ventricle, reducing the diastolic blood pressure. And since the left ventricle is receiving more amount of blood from left atrium as well as from the aorta, so it has to work more, stroke volume is more, as a result of which systolic blood pressure is also more. Clear? So that is the reason why you see a widened pulse pressure. Okay, so that's a very good question, I feel. Okay, so this image is just for your reference later on. Now moving forward to some pulmonary physiology question, and I think this kind of language you will always see in your exam paper. Okay, so very good Bhuvan, very good Bhuvan Raghu. Thank you, gentlemen. I am trying my level best. Thank you. Right. So moving forward to next question from pulmonary, and I'm very hopeful that you will have some question from this topic. Right. So here what you see, a chronic smoker with progressive breathlessness and chronic cough. Now pulmonary function test, it reveals increased total lung capacity, then increased residual volume and classically reduced FE1 to FVC ratio. Which of the following is the physiological changes responsible for this increased residual volume? Very good Aman Sherao, very good bache. Okay, Bhuvan, very nice strategy, gentlemen, very nice strategy. Okay, so I think the moment you find this chronic smoker, okay, then progressive dyspnea, right, then chronic cough, and classically pulmonary function test showing you increased total lung capacity, increased residual volume and decreased forced expiratory volume in first, second to forced vital capacity. So this is all very good. So this is all classical case of chronic obstructive pulmonary disease, right? So it is chronic obstructive pulmonary disease. And now here the question is why there is increased in residual volume. Why there is increased in residual volume? So before that we should know what is the definition of residual volume. Now residual volume, I think most of you must be knowing, it is the amount of air present in alveoli at the end of, classically you have to write maximal inspiration, right. So the patient will try his level best, but despite that some amount of air it remains in the lungs, and that is residual volume. Now in a case of CPD, very good, Vuban. So in case of CPD, this is a little higher, and why? Because what happens, as the patient is trying to forcefully exhale, there is closure of smaller airways, right. So there is premature closure of the smaller airways, and this during exhalation, and this what results in a retention of the air within the alveoli, increase in the residual volume. Now here there is mention of loss of elastic recoil. Now this can be, if there is rupture of alveolar walls, and I think this goes more in favor of emphysema. Okay, so anyway, that's not a diagnosis making question at all. So if you say chronic bronchitis, going with the presentation it looks like that, but going with this word it looks more of emphysema. But the thing is that it is a case of COPD, and the basic mechanism is premature closure of smaller airways during expiration, and therefore the amount of the air from the alveoli cannot be pushed out, so it remains within the alveoli, and therefore there is increase in residual volume. So that is the physiological basis of this question. Everyone is right, no problem. Okay, chalo, moving forward to next question. A 28-year-old mountaineer rapidly ascends to an altitude of 4,500 meters, and then he develops hyperventilation, obviously because of hypoxia. Now what change can be seen immediately after hyperventilation? So obviously ascend to high altitude, and we know that at high altitudes there is hypoxia, right. So fall in partial pressure of oxygen, right, that's hypoxia. So as somebody moves to higher altitudes, there is hypoxia. Now how the body will react to that? The body will react to that by ventilating more, so that is known as hyperventilation. Clear? So that's the usual response to high altitudes. Now what will happen, as a subject is ventilating more, there will be carbon dioxide washout. So what will happen if you breathe more? We are moving the carbon dioxide out of the body, and as the carbon dioxide is washed out, so there will be fall in PaCO2. When there is a fall in PaCO2, what will happen to pH? The pH will increase, and this is known as alkalosis. Okay, so increased pH is what? Alkalosis. Now here the consideration is PaCO2. So this will be which type of alkalosis? This will be respiratory alkalosis, isn't it? So there will be decreased PaCO2 and increased pH, and yes, if this question is framed in terms of acidosis alkalosis, the answer has to be respiratory alkalosis. Okay, so please remember this, pH is increased, so it has to be alkalosis, and since it is related to carbon dioxide, so you will call it respiratory alkalosis. Okay, very good, Aman. Chalo, moving forward. Now next question. A 32-year-old patient develops sudden pleuritic chest pain, and so there is sudden pleuritic chest pain and dyspnea after prolonged immobilization. Arterial blood gas analysis reveals hypoxemia, and the diagnosis came out to be pulmonary embolism as shown by pulmonary angiography. Now, which physiological abnormality is primarily responsible for hypoxemia? So yes, I think the diagnosis is pretty obvious. So it's a case of pulmonary thromboembolism or pulmonary embolism, whatever you want to write. And classically there is dyspnea, okay, and which is the earliest manifestation here, and this is coming after prolonged immobilization. So there is possibility that there might be deep venous thrombosis which has led to pulmonary embolism. Anyway, that's not the point of discussion. Now what is happening here? There is hypoxemia. So what is the reason why there is hypoxemia? So what happens in pulmonary embolism? Say if suppose these are the alveoli is surrounded by a blood vessel, of course, right? So some blood vessels like this. So in this alveoli, oxygen is coming, right? So this oxygen is coming nicely, but since there is embolism, so there is no blood flow. Clear? So there is ventilation, but there is no perfusion. Clear? So there is ventilation, but there is no perfusion. So this is dead space. This is the concept of dead space. Now here, this is the concept of dead space. Now which type of dead space is this? Yes, so this is alveolar dead space. Clear? So this is alveolar dead space. So there is increased alveolar dead space because of ventilation, yes, but without perfusion. So there is no blood flow because of that embolus, and but the normal process of ventilation is going on. So oxygen is coming, but it cannot be extracted. So it's a kind of alveolar dead space. And I think most of you must be knowing what do you mean by the word anatomical dead space. So anatomical dead space, this is actually a normal entity, right? This is not abnormal. Yes, this one is abnormal. Why anatomical is normal? Because suppose the oxygen which is present in trachea, it is of no use because it cannot be extracted. So that is a normal anatomical dead space. And yes, if we add the two, so if we add the two, that will be known as physiological. Clear? So what is physiological? So physiological dead space is anatomical dead space plus alveolar dead space. Clear? So this is anatomical dead space and this is alveolar dead space. Clear? So in pulmonary embolism, and yes, Bhuvan, you are absolutely right. If we take the ventilation perfusion ratio, since the perfusion is 0, so this ratio will come out to be infinity. Yes, very good. Wonderful, wonderful. So this is the simpler correlation of the concept of dead space, right? Please remember. So moving forward to next question. 58-year-old man with long-standing diabetes mellitus presented with progressively increasing pedal edema. Lab investigations reveal serum creatinine of 2.1. Inulin clearance is measured to determine GFR. Now, why inulin is the preferred marker for measuring glomerular filtration rate? So, the main thing which is being asked is like why we are preferring inulin. So, if we just take the facts here, like properties of an ideal substance to measure GFR, right? So there are 5 properties. Number 1, it should not be synthesized in the body. Okay. Number 2, it should not be metabolized in the body. Okay. Then number 3, it should be filtered easily at glomerulus. Okay, it should pass easily. Then number 4, there should be no reabsorption and there should be no secretion in renal system, right? So this is in renal system. So it means the substance should move out through the body unchanged. Whatever the amount we are giving, it should come out as such, and therefore we can correlate it with GFR, because whatever we are given, whatever amount comes out, we can correlate, okay, this is the actual GFR. So inulin is preferred for this because it is freely filtered, right? Neither reabsorbed nor secreted by the renal tubules, right? So this is the properties of a substance, of an ideal substance which we are using to measure GFR. And yes, obviously our preferred one is inulin, and please don't mix with insulin. Okay, so moving forward. Now a male presents to the emergency department with sudden onset weakness of right upper and lower limbs, right? So here it is right upper limb and lower limb. So this is what? This is hemiplegia. Okay, one half of the body, right upper limb, right lower limb. Now on examination, there is spasticity, hyperreflexia and extensor plantar response. So if you write it, spasticity, then hyperreflexia and extensor plantar. So the moment you have these 3 keywords, I think most of you can answer that this is classical case of upper motor neuron lesion, right? So spasticity, increased or brisk deep tendon reflexes, extensor plantar, that is positive Babinski sign. Clear? So this is classical for upper motor neuron. And then sensory is normal. MRI is showing an infarct which is involving the posterior limb of left internal capsule. Yes, obviously, if it is upper motor neuron manifesting on the right side, the lesion has to be left side. Okay, that I think all of you must be knowing that it is always contralateral. So manifestation on the right, it means lesion on the left. Now here it has been given to you that there is lesion of the posterior limb of the left internal capsule. So posterior limb of internal capsule. Now if you can correlate little bit of anatomy, we know that there are the corticospinal fibers which are coming down through the posterior limb of internal capsule. So obviously this is a case of upper motor neuron corticospinal tract lesion. Now the question is about which physiological principle best explains the development of spasticity several weeks after the stroke. So now what usually happens, that the upper motor neuron or the upper centers, they are actually controlling the lower centers. They are always inhibitory to the lower centers. So here the motor cortex is always inhibitory to the spinal cord. So if there is any involvement of the upper motor neuron pathway, it means that inhibitory effect of the motor cortex over the spinal centers is lost. So there is loss of descending inhibitory influence of the motor cortex over the spinal stretch reflexes, right. So this is obviously this is a descending pathway or descending tract, and this actually controls, or you can say inhibits, the spinal reflexes. So once there is damage to the upper motor neuron pathway, it means the control of the motor cortex over the spinal reflexes is lost, and therefore now these spinal reflexes, they become more or less autonomous. They don't have any control over them. So that's why we see spasticity, or even we'll see hypertonia here. So we can write increased tone, that is hypertonia. So that's the classical features of upper motor neuron. So a very wonderful question integrating medicine with physiology. So here it is just because the inhibitory control of the motor cortex to the spinal cord is lost. And even in physiology we always teach that the upper areas, they always inhibit the lower areas, right. So they have an inhibitory control over the lower areas. Now moving forward to next question. A 25-year-old male sustains a stab injury. Okay, so there is a stab injury to the right half of the spinal cord. Okay, right half of the spinal cord, and then he has loss of vibration proprioception on the right side and loss of pain temperature on the left side. Now which physiological feature explains this pattern? Yes, very good. This is a classical Brown-Sequard syndrome, right. So here what you need to remember, so this is a classical Brown-Sequard syndrome, which is also known as hemisection of the spinal cord, right. So this is also known as hemisection of the spinal cord. Now here you need to just remember one thing, like especially with respect to the ascending tracts, and whenever we discuss ascending tracts from exam point of view, we discuss only two. One is the dorsal column and the another one is the spinothalamic tract. Okay, so this is the spinothalamic tract. Now what you need to remember is the area of decussation, means they are ascending from the right side when they will move to the left side. So dorsal column, it decussates at the level of medulla, whereas spinothalamic tract, it decussates at the level of spinal cord itself, right? So that's why if there is a, suppose if this is the spinal cord, say something like this. So if there is injury to, say this is the right side as given in the question, right? So there is injury to the right side, this is the left side. So what will happen, the dorsal column, which is somewhere like this, so this is all dorsal column here, right? So this is the dorsal column. So dorsal column are carrying the fibers from the same side, because we know that the fibers will cross to the other side at the level of medulla, but the fibers which are present here of the lateral spinothalamic tract, they have come from the other side. So this is the spinothalamic tract and this is the dorsal column, obviously. So if there is injury to one side, obviously there will be involvement of the dorsal column and the spinothalamic tract, but since the dorsal column are ascending from the very same side, so there will be loss of vibration, proprioception, fine sense, stereognosis, all on the same side. But since the spine and the spinothalamic tract has already crossed over, so whatever the fibers are there on the right side, they are actually taking the impulse from the left side. So there will be loss of pain and temperature on the left side. So that's a very beautiful concept and has been asked many number of times, right? So what you need to remember, dorsal column same side and spinothalamic tract opposite side. So just remember this much. And yes, you should know the sensory modalities. Yes, very good, Bhuvan. And just discussing the ascending tracts. Obviously, there will be involvement of the corticospinal fibers as well, right? So this is in terms of Brown-Sequard syndrome. In terms of ascending tract, dorsal column same side. Please remember it, or else make some mnemonic, but please don't do any sort of mistake in this particular question. Very favorite for exam setters, has been asked in almost every exam. Okay, so I think this is pretty easy to answer. So spinothalamic tract fibers, they cross after entry. Okay, so as they enter into the dorsal column, the dorsal horn, they quickly change the direction to the other side. So this is the lateral spinothalamic tract. Chalo, moving forward to next question. A woman develops diplopia and ptosis that worsens towards the evening, right? So worsens at the evening after prolonged activity, reading here. Then repetitive nerve stimulation demonstrate a decremental response. Now, what physiological process at the neuromuscular junction is primarily impaired? Now, this is a very favorite question for exam setters, and I think most of you must have understood what condition we are discussing here. So, lady, right? So, a lady with double vision, that is diplopia, right? So this is diplopia or double vision. Then there is ptosis. Ptosis is what? Drooping of upper eyelid, and it worsens with activity, right? And therefore more pronounced at the end of the day, that is in the evening, right? And there is a decremental response. So repetitive nerve stimulation, decremental response. I think, yes, very good, Bhuvan, very good. I am really happy that you corrected yourself. So this is a classical for myasthenia gravis. Okay, so this is classical for myasthenia gravis, and I think most of you must be understanding or remembering the pathology, because there are antibodies which are directed against the post synaptic cholinergic, especially nicotinic, right, receptors. Clear? So this is, so there is post synaptic acetylcholine receptor activation which is impaired, right. So this is in terms of impaired. So obviously this is impaired because there is destruction of those postsynaptic acetylcholine receptors, right. So please study about myasthenia gravis as much as possible. This is very favorite for exam setters, and yes, Bhuvan has already summarized a lot of thing about myasthenia gravis. Very good, Bhuvan. Okay, so this is related to physiology actually. Chalo, next question. A healthy volunteer accidentally touches a hot metal surface and immediately withdraws his hand before consciously perceiving pain. Which physiological principle best explains this response? Now, I think this is a yes, a very basic phenomena which most of us has even experienced ourselves, right? So there is a classical withdrawal reflex which is mediated through spinal interneurons. So what is happening here? The moment there is a noxious or a painful stimuli, what happens? Quickly there is withdrawal reflex, and this is mediated at the level of spinal cord. Clear? So spinal cord itself is mediating this withdrawal reflex, and later on there is cortical perception of pain. So even before the impulses they reach up to the brain, spinal cord at the level of spinal cord at its own level, it mediates this withdrawal reflex where there is flexion of one group of muscles, and this is supplemented by relaxation of antagonist, isn't it? So this is a classical withdrawal reflex mediated at the level of spinal cord. Great, great. Chalo, moving forward to next question. A lady presents with menorrhagia, okay, excessive menstrual blood loss, fatigue, exertional dyspnea for the past 6 months. Okay, so then there is low hemoglobin, 8.2 only, and there is microcytic hypochromic anemia. Oxygen saturation is almost okay. Now, which physiological adaptation primarily helps in maintaining tissue oxygen delivery even in chronic anemia? Right now, again, this hematology, especially anemia, is very important from exam point of view. So classically, she is having menorrhagia, that is increased menstrual blood loss. So this probably had led to the iron deficiency anemia in this particular case, which is microcytic hypochromic anemia here, right? Hemoglobin is already less, but saturation is okay. Now, how, despite having hemoglobin is less, but then how the oxygen delivery is maintained? So yes, this is because of increase in 2,3-bisphosphoglycerate, and we know that if this compound is increased, it will promote unloading of oxygen from hemoglobin, right? So increase 2,3-diphospho bisphosphoglycerate, it will shift the oxygen hemoglobin dissociation curve to which side? Obviously it will shift the curve to right side. So remember, R means released. So there is good amount of unloading of oxygen from hemoglobin. Okay, so this is the mechanism, that despite having low hemoglobin, but this is compensated by increase in 2,3 bisphosphoglycerate, and this shifts the oxygen hemoglobin dissociation curve to right, and that's why the oxygen delivery to the tissue is maintained. So this is how clinical fact has been correlated with physiology. Next question. Now, a 22-year-old with hemophilia A develops recurrent hemarthrosis involving the knee joint, and then there is raised APTT, activated partial thromboplastin time, but normal bleeding time, right? So APTT is high, bleeding time is normal. I think everyone can answer this, which coagulation factor is at decrease here. So hemophilia A, and this is, yes, recurrent hem arthrosis, means there is collection of blood in joint, especially knee joint, and there is increased APTT, but BT is normal. Now, if bleeding time is normal, it means platelets are normal, and if APTT is more, it means the intrinsic pathway is affected, and hemophilia A, I think all of you must be knowing, it is because of deficiency of the factor 8, right? So in hemophilia, raised APTT and normal BT. Please remember this. Very good, Bhuvan. And yes, I think if you go a little bit in pathology, sometimes there is a question about the inheritance of hemophilia, because always and always it is affecting males. So it is affecting males only, and then also no father to son transmission. So what does this indicate? This is classical XLR. Okay, so please remember, this is classical X-linked recessive. Okay, so classical X-linked recessive. So please read hemophilia properly, and also von Willebrand disease. If we go into medicine, we will take that entity as well. So for the time being, this is classical for hemophilia A. Okay, factor 8 deficiency. Chalo, next question. A male with chronic kidney disease has normocytic normochromic anemia. Iron, vitamin B12 is all normal. Now, what is the reason for this anemia in this case? Very good, Bhuvan, very good. So, now the case is chronic kidney disease, and he is having anemia. Then iron, vitamin B12 all normal, so it means there is no no involvement of iron or macrocytic or megaloblastic anemia. And here classically this is normocytic, normochromic. So this is because of there is one hormone which is needed for erythropoiesis, and the name itself suggests that it is needed for erythropoiesis. So very good, very good, Nishtasoni, I'm sorry, very good bache. So yes, this is erythropoietin. So the peritubular interstitial cells, they secrete erythropoietin, and as the name suggests, it is related to erythropoiesis. So if there is deficiency of this, obviously there will be anemia. Clear? So this is the reason why there is anemia, normocytic normochromic anemia in a case of chronic kidney disease patients. So there is reduced erythropoietin, which usually comes from interstitial cells of the kidney, and obviously the stimulus is hypoxia. So hypoxia, this is the stimulus. Clear? So this is how you can associate all these keywords here. And yes, those who have seen any case of chronic kidney disease, we always give injection of erythropoietin, because we have to carry on the process of erythropoiesis in the patient also. So erythropoietin injections are given for the very same reason. Then moving forward to next question, woman presents with fatigue, weight loss, recurrent episode of dizziness, and there is generalized hyperpigmentation. There is hyponatremia, hyperkalemia, low cortisol, and elevated ACTH levels. Now, why we see hyperpigmentation in this patient? So if you look at the case here, is we have hyponatremia, then hyperkalemia, clear? Then there is low cortisol. This all suggests that there is adrenal insufficiency. So decreased adrenal activity or adrenal insufficiency, and this is what is actually Addison's disease, right? So I think most of you can make out this diagnosis. So this is Addison's disease, and here this is actually primary. So this is primary here. It means the fault is within the adrenal gland. Therefore, there is less of aldosterone, less of cortisol, right? So there is less of aldosterone, and obviously it is already given there is less of corticosterol. And now if we look at the normal axis, now what happens? Suppose this is hypothalamus, then anterior pituitary, and then the adrenal gland. So this is what is known as the HPA axis, right? So from here there is corticotropin releasing factor, from anterior this is ACTH, and from here there is cortisol. Now this cortisol, it sends a negative feedback inhibition to anterior pituitary, and if this is already less, it means this inhibition will not be there, and therefore there will be raised ACTH level, which is mentioned in this question. So it means there is less level of cortisol coming from the adrenal gland, and therefore there is no negative inhibition of the anterior pituitary, particularly for ACTH. So the ACTH levels are increased. So this is classical primary adrenal insufficiency. Now what happens? ACTH and MSH, they share resemblance because they have a common substance for their origin, that is pro-opiomelanocortin, and this MSH as the name suggests, this is what? Melanocyte stimulating hormone. Clear? So, as the name suggests, it will stimulate melanocytes. And what is the function of melanocyte? It will lead to production of melanin, and this will produce pigmentation. Clear? So, this is how you can correlate this pathology or the disease with the physiological process. So, this is important. Now, remember one thing, this pigmentation, it is only seen in primary. It is not seen in secondary, where there is already less of ACTH leading to less cortisol. Okay? So, it is only seen in primary, where the adrenal gland is itself at fault. Very good. So, the answer will be increased secretion of melanocyte stimulating hormone, which is derived from propiomelanocortin, which is the same substance which is which is forming ACTH. Clear? So, that is why there is hyperpigmentation in primary adrenal insufficiency. Chalo, moving forward to next question, and again a very important question which has been repeated over the years. A lady underwent total thyroidectomy, right? So, there is removal of the thyroid gland for papillary thyroid carcinoma, but within 48 hours she develops circumoral numbness, carpopedal spasm and a positive Trousseau sign. Now, what is the reason for these manifestations, right? So, there is total thyroidectomy, surgical removal of the thyroids. Obviously, the reason was papillary thyroid carcinoma. Now, what is happening after that? Circumoral means around the mouth, right? So, circumoral numbness, carpopedal spasm. Carpo means hand, pedal means foot. So, the small muscles, they go into a spasm, and there is a positive Trousseau sign. It means if you inflate the cuff of a BP apparatus, there will be carpal spasm. Sorry. So, all these is suggesting towards the possibility of hypocalcemia. I think all of you can make out that. So, there is hypocalcemia. Very good, Nehal, very good, bache. So, there is hypocalcemia. Now, why there is hypocalcemia? We are just removing thyroid. So, it is actually there is advertent by mistake removal of parathyroids, or there is devascularization of parathyroid. Clear? So, either the blood supply has been abolished, or the parathyroid are mistakenly removed. So, that is why there is no parathormone, and hence there is hypocalcemia, which manifests as which leads to increased neuromuscular irritability, right. So, there is increased neuromuscular irritability, and that is why we see carpopedal spasm, or when sometimes you use the word tetani. So, this is a classical description of hypocalcemia, that is reduced extracellular calcium, and this reduces the threshold for action potential generation, because it increases the permeability for the sodium of the sodium channels. So, the sodium, it can move freely inside, and therefore, the threshold for action potential generation is lowered, right. So, this is reduced calcium levels, that is hypocalcemia, increasing the neuromuscular irritability. Clear? So, that is a beautiful presentation of hypocalcemia with accidental injury to the parathyroids in the form of removal or loss of blood supply. Then moving forward to next question, 34-year-old woman presents with weight loss despite increased appetite, palpitations, heat intolerance, and excessive sweating. Now, the diagnosis has already been given to you, so it's a case of grave disease. Now, what is the reason? What is the physiological reason why this lady is having warm and moist skin? So here, this is already the diagnosis has been given. It's a case of grave disease where the lady is presenting to us with hyperthyroidism. Okay, so there is increased appetite, we call it voracious appetite. The patient will eat as if he or she hadn't eaten since days, but despite that there is weight loss, there is heat intolerance, right, and there is excessive sweating. So what is the reason for this? Because there is increased basal metabolic rate. Okay, so the reason is increased basal metabolic rate. So there is heat intolerance, there is excessive sweating. Now, Kartikeya Seni, very good. So what happens because of this increased heat production, right? So there is increased heat production. Now this has to be released, this has to be dissipated from the body. And how it can be dissipated? By increasing cutaneous blood flow, right? So the blood flow to the skin is increased and therefore the skin becomes warm, moist, right? So this is the reason why in a case of hyperthyroidism we see warm, moist skin. Okay, so there is increased cutaneous blood flow which is secondary to the increased heat production. So this is a classical hyperthyroidism. Okay, so there is more heat production because of increase in basal metabolic rate, okay, because of excessive thyroid hormones. Chalo. Next question. A healthy volunteer receives IV infusion of insulin. So IV infusion of insulin during a metabolic physiology experiment, and as a result of this, what will happen? Plasma glucose falls rapidly. Now, as the plasma glucose level is falling rapidly, which hormone is released at first as a primary physiological defense against hypoglycemia? Now, what is happening? IV infusion of insulin. Obviously, we know that insulin works to reduce blood sugar levels. Now, when the blood sugar levels are falling down, there will be release of one hormone which is, you can say, anti-insulin, and that will try to restore the blood sugar levels. So that is, I think most of you can answer, this is glucagon. So the first is always glucagon, and it will act to correct the falling blood sugar levels. Very good, Kartikeya Seni, right? So the very first is glucagon. It will be followed by epinephrine, growth hormone, or cortisol, right? So first it will be glucagon, then epinephrine will also come into role, then growth hormone will also come, and then cortisol will also come to restore the blood sugar levels. But the initial or the first one is glucagon. Clear? So the moment there is any fall in blood sugar levels, glucagon will come to rescue the body. Now, in this particular case, it is because of IV infusion of insulin. Suppose if it is a physiological process where the insulin which is normally secreted in the body, it is causing hypoglycemia, the very first response will be decreased level of insulin, right? So the very first will be decreased level of insulin, then there will be increased level of glucagon. That is in case of physiological scenario, but here it is just because we are giving it from outside, so we cannot control the level of insulin as such. Oh, very good Alfala, बहुत बधाई हो, lot of congratulations, and I am very sure you were, during those sessions you were always answering so perfectly, especially those recall sessions. Congratulations to you. And then moving forward to the last question of today's session, and this is about men who is presenting with infertility. Then semen analysis is showing azoospermia. Testosterone is normal, but FSH is markedly elevated. Then testicular biopsy shows selective destruction of seminiferous tubules and preservation of Leydig cells. Now, which hormone produced by the damaged cells normally inhibit FSH secretion? So I think if you simply go with this last statement only, you can answer the question, but let us take this case as a whole. So here the testosterone levels are normal, okay. FSH is markedly elevated. Now testosterone, it is secreted from Leydig cells, and testicular biopsy, it is showing destruction of seminiferous tubules. And these seminiferous tubules actually contains Sertoli cells, and Sertoli cells, it releases inhibin, and this inhibin inhibits FSH. Although FSH promotes release of inhibin, but inhibin inhibits FSH, right? So here, since there is damage to the seminiferous tubules, there is damage to the Sertoli cells, so there is no inhibin, therefore FSH has no negative feedback inhibition, and therefore the levels are extremely high. Testosterone has nothing to do, it is related to LH, right? So it is going unaffected here. So here the answer is inhibin B, right? So this is also one of the favorite areas from where the question can be framed, right? So here the answer should be inhibin B. So with this we can end today's session, and yes, extremely happy to find one gentleman here, MS Alfala. He just cleared his recently concluded FNG, so that's a moment of pride for all of us, and I'm very sure that many of you will crack NEET-PG also with some good rank. So that's enough for the time being. Very shortly I'll come up with one more subject. Till then, keep on studying. God bless. Good night. Bye bye.